Hello and welcome to part 2 of your online lecture for thoracic and lumbar spine functional anatomy. We're moving into ligamentous anatomy. We just finished up with bony. We talked about vertebral disc anatomy. And now we really have to talk about the static structures which are responsible for maintaining stability throughout the vertebral column. The first two ligaments that are listed here are the anterior and posterior longitudinal ligaments. As their name implies, anytime we give a ligament a specific name, a directional name, most often that's where that ligament is going to lie relative to another anatomical structure. So that anterior longitudinal ligament is going to live just anterior to the vertebral body. And we can see that here in this image. So it lives or is housed more anterior or towards the front of the trunk, right? We can see that that anterior longitudinal ligament is going to have a proximal attachment to the occiput, where it's thin, and then as it travels down the spinal cord, it becomes thicker as it inserts onto the sacrum. Its major role, since it's an anterior ligament, is going to be in limiting the amount of trunk extension that a patient will have. And this image here is extremely valuable if we look at it from an anterior longitudinal ligament perspective. So if we lean in an extended position, if this ligament is lax or ruptured or compromised, one of the things that we can see oftentimes is we are at an increased risk for any type of spinous process injury, because those spinous processes will either butt up against one another, or you can suffer from one of the most common extension injuries, which is known as a spondylopathy, right? Where we have disruption to the pars interarticularis, which is an extension of the lamina. So we can see that if we have injury or compromise to that anterior longitudinal ligament, the patient is at risk for suffering from any type of extension pathology, because we don't have a limitation in that direction of motion. One other thing that's important to note about the anterior longitudinal ligament is that it plays a major role in providing shape or structural integrity to the vertebral disc. And you can see that here as it spans the anterior portion of the vertebral body. So you can have some type of herniation in the anterior longitudinal ligament, which would then allow the annual fibrosis to kind of protrude through, secondarily allowing the nucleus pulposus to kind of protrude through, creating different signs and symptoms, most often neurological signs and symptoms. So the integrity of the anterior longitudinal ligament is extremely important, not just for limitations in range of motion or increased risk of extension injuries, but also when we have compromise to this ligament, when we have an overstretching or a laxity to that ligament, oftentimes you can see a disc protrusion or herniation. On the opposite side of that ligament and vertebral body, so on the posterior side of the vertebral body, we have the posterior longitudinal ligament. Very similar to the anterior longitudinal ligament, it's going to have a proximal attachment to the occiput. And so that the ligament, the posterior longitudinal ligament, is going to be thicker in the cervical spine region, and then it will thin out as it progresses distally to insert onto the sacrum. The other thing that is notable about the posterior longitudinal ligament, I actually think it's cool, is that it lines the most anterior portion of the vertebral canal. And remember that vertebral canal is the space through which the spinal cord kind of moves. So it is just anterior to the spinal cord, right? So its major role is to limit spinal flexion. The anterior longitudinal's major role is to limit spinal extension. And so any compromise to the posterior longitudinal ligament, and we'll see an increase in the risk of the patient developing flexion, when I'm thinking lumbar flexion injuries over time. The next ligament we're going to talk about is the supraspinous ligament. We can see that ligament here. Its major role is that it attaches to each of the spinous processes within the spine. And so when we think about the supraspinous ligament, one of the major roles is, again, just like the posterior longitudinal ligament, its major role is to limit the amount of flexion that occurs. So we can see, because it's a more posterior ligament, anytime that spine moves into a flexion moment, so we move into a flexion moment, those supraspinous ligaments, their major role is to just limit the amount of separation between the spinous process, but more importantly, to limit the amount of trunk flexion that is going to be occurring. Big role, I think, when we think about it, really is just to connect the spinous processes to the most proximal spinous process to the distal spinous process. You might notice there's a ligament here. So we have a more posterior ligament in the supraspinous ligament. Then we have a ligament that is housed in between, like on the side or on the lateral portion of the spinous process. So they essentially, these intraspinous ligaments, what they really do is kind of fill the space between the spinous processes, right? Their major role, again, is structural integrity to the amount of, what do you think? Great, trunk flexion that's going to occur. Again, it is a posterior ligament, and so its major role is to kind of limit motion opposite that. So in this case, again, if that spine is flexing, those ligaments are going to get stretched, and if they get overstretched, they're going to contract and pull the spine back into a neutral position. So all in all, right now, when we're thinking about ligaments that contribute to flexion, we've talked about the posterior longitudinal ligament, the supraspinous ligament, and the intraspinous ligament. The last ligament that we're going to talk about is the ligamentum flavum. It's this muscle, or I'm sorry, this ligament right here. We can see that there. The ligamentum flavum essentially is responsible for kind of lining the, lining the posterior aspect of the vertebral canal. That's the best way that I want to say that. In addition to that, it also is responsible for connecting the lamina, so connecting the superior lamina to the inferior lamina of the vertebral body below it. But again, really its major role is to line the most posterior aspect of the vertebral canal. Now, you all might recall that the posterior longitudinal ligament is going to line the anterior portion of that vertebral canal, and then we have the ligamentum flavum, which is really two different bundles lining that posterior portion of the vertebral canal. And that's beautiful, right? We have this spinal cord moving through the vertebral canal, and then we have these strong ligamentous structures both on the anterior aspect of that spinal cord and on the posterior aspect of that spinal cord, really creating another line of protection for the spinal cord. That ligamentum flavum travels from C2, so it doesn't start at the base of the occiput. And the reality is, remember, the C1 vertebrae really has a deep connection to the occiput, and so the ligamentum flavum can't quite live there. But as we move from C2 all the way down to S1, we can see that the ligamentum flavum is certainly intact. So as we take a deeper look at the ligamentum flavum, I said, remember that the ligamentum flavum is going to connect the lamina of one vertebrae to the lamina of another. And remember, the ligamentum flavum, it's in pairs, right? So there's a right side and a left-sided ligamentum flavum. And that's important because we have a right side and a left side lamina. And so the right side ligamentum flavum is going to connect the right lamina of one vertebrae to the right lamina of the other vertebrae. And again, its major role is going to be to assist and or limit trunk flexion. And one of the things that I've listed down here is its makeup. And I didn't do that for the other ligaments because their makeup is a tad bit different. But as we dissect and really truly appreciate the ligamentum flavum, because it has that direct connection to the lamina, one of the things that it does is it really, not only does it resist trunk flexion, but when we move into a hyperflexion moment, it will contract and really truly be responsible for moving that vertebral column back into a neutral position. And that's because of its makeup here. So it consists of 80% elastin and 20% collagen. And that makeup really, really allows the ligamentum flavum, that elastic property, really, really, truly allows that ligamentum flavum to be instrumental in returning the trunk to a neutral position following a flexion moment, right? So it's more elastic and more, I guess, stretchable than the ligaments that we've talked about prior to that. The other thing that we know that the ligamentum flavum does is it also reinforces the facet joints. So it plays a major role in kind of making sure the facet joints maintain their integrity and stay intact. And then last but definitely not least, we have the facet joint. We can look at the facet joint here, right? We can see that it's a joint, so it's where two bones actually come together. We can see that it's going to exist in between, where are you? In between spinous, the superior spinous process and inferior spinous process, we'll find kind of that facet joint right in here. So we'll palpate that in lab so that you can understand exactly how to palpate it. Next, what we want to talk about is the muscular anatomy. We have two different types of muscles really that we are going to talk about on the next few slides. We have our extrinsic muscles and our intrinsic muscles. Our extrinsic muscles are, as the slide says, but let me bring it home for you. Their major role is they're large global motor movers. And so they play little role in moving the spine, but play a major role in scapular thoracic rhythm. So glenohumeral joint movement, scapular movement, for example. Even in some regard, you could have thorax movement, but their major role is in gross motor movement. Your intrinsic muscles, however, because they are closer to the spine, relative to the spine, ultimately they play a major role in creating spinal stability and then also allowing the vertebral column to move into its different ranges of motion, right? Which brings me to a tangent. The lumbar spine and thoracic spine really have 3 degrees of motion, right? The first one is in the sagittal plane with flexion and extension. The second one's going to be in the frontal plane with lateral side bending. And then the third is going to be in the transverse plane, right, with the rotary motions. So I wanted to make sure that I said that. I think I did in our first online lecture. So when we look at the extrinsic muscles, those extrinsic muscles, let's think about them. Let's name them. So we've got the large lat, which is going into this white structure known as the thoracolumbar fascia. And you can see one of the beautiful things about the thoracolumbar fascia is you can see that the way that it pinnates, right? And it pinnates in multiple directions. And this is beautiful because not only does the thoracolumbar fascia receive any forces coming from the lumbar spine, and not only does it transfer it proximal throughout the vertebral column, you can also see that it's a force dissipator. In other words, it will take some of that force and kind of send it to different points in the body. So that the thoracolumbar fascia is extremely important in force transference, and I would also say force dissipation. But that latissimus dorsi is going to come in and it's going to have an insertion onto the actual thoracolumbar fascia, and that latissimus dorsi is extremely important for extension of the spine, most definitely, and then stabilization of the lumbar spine via the thoracolumbar fascia. So major spinal extender, but then more importantly, because it does attach to the spine via the thoracolumbar fascia, it's a major lumbar stabilizer. So oftentimes if you have a patient who has low back pain, we focus on the glutes, most definitely. We probably focus in on the obliques, but how often do we actually do some latissimus dorsi work to help indirectly stabilize that lumbar spine? So that's extremely important. Other large extrinsic muscles that are going to kind of control motion at the trunk or the glenohumeral joint is going to be the external oblique and then the internal obliques. And so when we think about the external oblique, when we have contraction of the external oblique, and it's a bilateral contraction, so if both external oblique muscles are contracting, then we get flexion of the lumbar spine. But if we have just one side, one oblique is contracting, then we get rotation opposite that. So if the right oblique is contracting, we'll get rotation to the left. The internal oblique, however, if we have bilateral contraction, the beautiful thing about it is it's going to contract to kind of create stability about the lumbar spine. And it's also going to cause trunk flexion. And then when we have unilateral contraction, then the opposite applies to that of the external oblique. So an internal oblique unilateral contraction will cause rotation to the same side. Example, if my right internal oblique contracts, then I will rotate to the right side, right? If my right external oblique contracts, then I will rotate to the left side. So always think about those two. And there are other major muscles that are not represented on this image, such as like the trapezius muscle group, which is going to play a major role in either retraction of the scapula, if it's the middle trap, depression of the scapula, if it's the lower trap, maybe even some elevation of the scapula, if it's the upper trap. You have the rhomboid minor, rhomboid major, which again are not included on this image, but certainly also help with retraction and elevation of the scapula, and or maybe downward rotation of that scapula. So those extrinsic muscles, just keep in mind that they're major movers of the spine, they're major movers of the glenohumeral joint and the scapular thoracic rhythm. As we move to the next slide, we're going to see some of the muscles that are what we consider to be intrinsic muscles of the spine. And so they're either divided into kind of superficial and or kind of deep muscles. So let's think about it from like a superficial perspective. Most superficial anteriorly, we know that we have the rectus abdominis, for example, but that's going to be more of, I would say, more of an extrinsic muscle because its major role is going to be flexion of the lumbar spine and then indirectly flexion of the trunk. But some of our intrinsic muscles that we're really truly thinking about are the iliocostalis lumborum, which we'll see here, which means you have to kind of dissect a way to actually get there. When we look at the iliocostalis lumborum, one of the things that it does is it causes spinal extension, which makes sense. It's most posterior, but then it also, if it's just that side contracting, will also cause lateral bending of the spine to the same side. That longissimus, thoracis, will also do very similar things, extension of the spine, but then also it will do lateral bending of the spinal column as well. And then you get the iliocostalis thoracis, right? Some of these I'd never heard of until I started prepping for this, but major spinal extensors, and then also lateral flexion to the same side. So we can see like these three muscles right here, major muscles and back extension, which really creates stability about the spine, which is a major role of the intrinsics of the spine, but then also same side lateral bending. Now you have some muscles, the rotors, for example, which are going to cause spinal extension, but they're also going to be responsible for causing rotation. So the rotors will cause rotation of the spine to the same side. And then we also have a muscle, where are you? Called the multifidus. And we'll look here to see the multifidus probably best represented. The multifidus, a major role is when the multifidi contract. So when we have bilateral contraction of the multifidi, they create massive vertebral column stability. But when one side contracts, then we get rotation opposite. So you have those rotors, which will contract and cause rotation to the same side. You have the multifidi, which bilaterally, when they contract, create stability about the spine, but then unilaterally, when they contract, cause rotation opposite. So overall, those deep intrinsics, as you can see, really aid in mostly spinal extension, but then also help to perform some of our transverse plane motion, right? So rotation either opposite or rotation either to the same side of the spine. All in all, if we look at this spinal extension, when we think about spinal extension, we're thinking that that is a position of stability for the vertebral column. All right, let's go into neurology. I think what I want to say here regarding neurology is none of us, I think, are going to be neurologists, but having a great understanding of the lumbar plexus and sacral plexus will be extremely important to you all as you're doing an assessment of a patient with a lumbar spine pathology. So I'm going to skip a few slides and go to this clinical anatomy slide. There are really two plexi that we're concerned about in the thoracic lumbar spine region. That is the lumbar plexus, which we've talked extensively about in lower extremity, but I don't want to breeze over it. So that lumbar plexus is really going to start at T12, right? So the most proximal vertebral body before the lumbar spine actually starts is going to be T12. And then you have T12 all the way to L4. And we'll talk about why L5 isn't necessarily included in the lumbar plexus and gets included in the sacral plexus, but I'm sure you could kind of guesstimate the why of that. So L1 through L5 is going to innervate the anterior medial muscles of the thigh, the medial leg, and the foot. And you have the branches of L2 through L4, which will branch from the femoral nerve or the obturator nerve, depending on if it's the posterior branches or the anterior branches. And then last but not least, you have the sacral plexus. Sacral plexus, as the name implies, are a set of nerve roots that kind of emanate from the actual sacrum themselves. It's going to include nerve root L5. And again, it has to do with the same thing like T12, right? That we have to include the vertebral body just above that. Here's where lumbralization and sacralization are extremely important because it has an impact on neural anatomy as well. But the sacral plexus is going to be majorly responsible for innervating the buttocks or gluteal muscles, the posterior femoral muscles, so the hamstrings, and the entire lower leg. So let's take a deeper look. This is the lumbar plexus, if we could really look at it with all of the nerves kind of branching out of it. And the reason I think it's important is because we've talked a lot about femoral nerve. We've talked a lot about the obturator nerve maybe, but now we get a better glance as a whole regarding which nerves might be impacted if we have a patient who comes in and when we perform the lower quarter screen has certain signs and symptoms or a positive myotome or a dermatome or a reflex associated with that nerve root, then you start thinking about which nerves might be implicated. I'm going to start with your L1 nerve root because your L1 nerve root has some nerves that we haven't talked about, the iliohypogastric, the ilioinguinal, and the genital femoral. These three nerves right here are extremely important, even though we don't think about them from a sports medicine perspective. We certainly have to think about the larger picture and how those nerves might actually cause signs and symptoms in patients that we should be aware of as athletic trainers. I'll give you a brief example. The iliohypogastric, for example, and the ilioinguinal ligaments both innervate, or nerves both innervate the internal and external obliques, right? So if any compromise to the internal, external obliques, and maybe you have atrophy of those muscles, one of the things you have to be thinking is, okay, which nerve might not be functioning well? The genital femoral nerve, as you all know, are well aware of, is it's going to supply a lot of the genital urinary anatomical structures. So dysfunction in that area, and you're starting to think, okay, maybe it's the genital femoral nerve that has been impacted. So you can see how looking at this complex array of the lumbar plexus certainly makes you step back and think, okay, if I have a diminished dermatome and myotome or a diminished reflex, what nerve is impacted and what muscles or anatomical structures do those nerves supply? Here's a more robust look at the lumbar plexus. Everything that we do, we know that it emanates off of a plexus root, right? So that root's going to be L2 through L5. Then we also know that there is a branch. Most often the branch is going to be either anterior or posterior. And we have a division. We can see the posterior division is shaded blue. And the anterior division is just shaded yellow. You have terminal branches. Those terminal branches are always the final nerve that exists once we hit the final branch. The largest branch, right, is going to be that femoral nerve, and the one that we're most often concerned with, the one that supplies the anterior portion of the thigh. Your sciatic nerve, you can see it here. It's going to emanate off of L4 through S3. But it's a major posterior contributor to the posterior musculature. And you can see it's going to kind of exit through that greater sciatic foramen here off of the ilium. And what we know about that is it's going to branch into the common fibular and then the tibial nerve, right? So we can see that kind of happening here. That common peroneal nerve is going to branch down and supply the lateral compartment, right? You told me that. And then the tibial nerve is going to branch into the superficial posterior and deep posterior compartments, which will house gastroc soleus if it's superficial, or Tom, Dick, and Harry if it's going to be deep. And then if we go back to common peroneal, we know that that's going to be the lateral compartment, which will then be responsible or house the fibularis longus and the fibularis brevis. So I really love this image here. You can see the branches a little bit better, and you can see what things are being supplied. So as an example, we have the L4 through S3 nerve root, right? We can see that this is posterior. How do we know it's posterior? Because we see the sciatic nerve, right? Sciatic nerve is then going to supply the biceps long head, the semi, so all of the muscles of the hamstring. You can see that there. Then it's going to branch into the common peroneal, which will go down and supply the lateral compartment, or the deep peroneal nerve, which will supply the anterior compartment, right? Which will house the extensors and peroneus tertius. We can also see that it then will branch into the tibial nerve, right? And that tibial nerve will supply superficial posterior and deep posterior compartment. And just another beautiful way to see this. We can see the deep peroneal nerve coming into the anterior compartment and supplying the tibialis anterior, and then a lot of the extensor muscles. And then this is the common peroneal. You can see it supplying the peroneus longus and peroneus brevis. So just a beautiful depiction of how our nerves really do branch into multiple directions. And again, going back to that lecture on referred pain, kind of this hopefully will hammers it home. So if you want another way to look at that, you can do that as well. We will do the lower extremity myotomes and dermatomes in lab. Thank you for listening to the final component of the anatomy portion of this lecture.